We are excited that you are considering using the Arkansas Heart Hospital as your choice for bariatric surgery. As a statewide and regional leader in cardiovascular health, we have made a name for ourselves by providing excellence in all aspects of not just your medical care, but also the customer service that you deserve. We are continuing our mission by adding bariatric surgery as a service line. Dr. Samuel Bledsoe comes to us with a vast experience of over 1,100 cases and the direct care of thousands of surgical weight loss patients. We have assembled an excellent team of physician assistants, nurses, dietitians, psychologists, and exercise physiologists worthy of the Arkansas Heart Hospital name. We have done this to ensure that your weight loss procedure is as safe and effective as possible, and your experience as smooth and trouble-free. Now here is Dr. Samuel Bledsoe with more information about the Bariatric and Metabolic Institute at Arkansas Heart Hospital.
This is Kayla. In this picture, she's 27 years old and weighs 291 pounds. She's only 5 feet tall, so that puts her BMI at 57. She has depression, anxiety, reflux, high cholesterol, type 2 diabetes, and suffers from infertility. Her primary complaints are the insulin pump that is required to control her diabetes, and the fact that she and her husband have been trying to have children and she just can't have them. Now, fortunately, we live in a time where we can do something to help her and others like her. The problem of obesity is obvious in America. Over 2/3 of Americans are considered overweight, and over 1/3 is considered obese. While this affects millions of Americans, it affects Arkansans disproportionately. According to one report released September of 2016, Arkansas now has the 6th highest adult obesity rate in the nation. Arkansas's adult obesity rate is currently 34.5%, up from 17% in 1995. While obesity is damaging to communities, communities are simply made up of individuals like you. But the weight is only the beginning of the problem. Some of you are suffering from a host of medical problems brought on and worsened by your obesity. In fact, there's a list of over 30 medical conditions that are found at a far higher rate in the obese population than in the normal weight population. Some of the more common diseases brought on by obesity would be things like diabetes, high blood pressure, sleep apnea, and high cholesterol. But obesity impacts every body system, and the negative effects can be felt from the head in the form of migraines all the way to the toes in the form of gout. The effects don't end with medical issues because there are societal issues and social issues as well that go along with obesity. People tend to prejudge others due to body size and make unfair characterizations about self-control and self-discipline. And this can have real-world effects. A study from Vanderbilt in 2015 confirmed yet again that obese women earn less than their normal weight peers for the same work. Other studies have shown that this wage gap can be on the order of tens of thousands of dollars per year. What is clear is that the problem of obesity needs an effective solution. But in order to have an effective solution, we first need a good working definition. So what is obesity? Obesity is a disease of excess fat storage that is associated with other medical conditions, that is multifactorial, genetically related, lifelong, progressive, costly, and potentially life-threatening. I mentioned that obesity is multifactorial. Broadly speaking, there are 3 major factors, genetics being a much larger factor than most people would assume. The New England Journal of Medicine published 2 studies in the 1980s that are very interesting. One was a study of twins separated at birth. These twins were far more likely to be similar to each other than the people in the very home that raised them. The second study was an adoptive study. What they found was that the adopted children were far more likely to be like the biological parent than the parents that raised them. The conclusion is that genetics plays a huge role in obesity. The second factor is behavioral. I don't think it comes as any surprise to anybody that diet and exercise, or lack thereof, plays a role in health and weight. The third factor is environmental. That would be things like your spouse, your children, and your work. Your environment and social pressures will be different if you sell running shoes versus if you sell snack foods. These factors make a difference in a person's weight. But at what point do we decide that the weight is getting out of hand and into the medically concerning realm? We make that decision based on a measurement called BMI, or body mass index. BMI is a crude tool, but it's easy, so it is used a lot in medicine, and it's how we define how overweight a person actually is. It's based on height and weight. Knowing both height and weight is important. If you tell me that you're 250 pounds, that really doesn't tell me anything. You might be 5 feet tall and 250 pounds, in which case you would qualify for weight loss surgery. But you could be 6'8" and 250 pounds. Those are the measurements of LeBron James, the NBA All-Star. So we take that BMI calculation and apply it to individuals. If the BMI is less than 25, that's considered a normal weight. They're overweight if the BMI is from 26 to 30. Obesity begins at a BMI of about 30 to 35. Severe obesity is from 35 to 40, and morbid obesity is greater than 40. If a person decides that they want to lose weight, there are a number of routes to take. The first and most common is diet, exercise, and behavior modification. If you're of that mind, you could spend the rest of your life just studying diets. There are commercial diet plans and non-commercial diet plans. Some are based on best-selling books. Others are based on observational studies of healthy populations. Others are based on successful hospital systems, and some based on hit TV series. However, the research has shown that the results are usually minimal and not sustained. While we would encourage you to start here with any weight loss efforts, we would also encourage you to be realistic. Research has shown that a woman who is morbidly obese, that's a BMI of greater than 40, has one chance in 677 of attaining normal weight, while a morbidly obese man has one chance in 1,290 of attaining a normal weight. The odds of losing the weight and keeping it off through diet and exercise are dismally low. So if you fail, there's no need to be embarrassed. You just may need to consider other opportunities. Some pharmaceutical interventions are very common for those who struggle with their weight. But again, while the research would suggest that the results are a little better, especially when combined with a physician-supervised diet and exercise program, the overall weight loss is disappointingly small and the results are rarely permanent. Why? Because you can't stay on these medications forever. And when you stop the medication, the weight generally comes back, and often you put on a little more weight than when you started. The last option would be weight loss surgery, and as we will see shortly, this is the only option that scientific research has shown is both effective and durable. Even though everybody wouldn't be a candidate for weight loss surgery, there are a lot of people who are potential candidates. About 25 years ago, the National Institute of Health established criteria for weight loss surgery. If your BMI is greater than 40, that's all you need to qualify for weight loss surgery. If your BMI is greater than 35 and you have medical problems like diabetes, high blood pressure, or sleep apnea, then you qualify for weight loss surgery. Recently, the effects of bariatric surgery on medical problems has been so well established that we will operate for a BMI as low as 30. So the first hurdle is just qualifying medically. But we do ask for a few other things. We do want you to have failed diet, exercise, and behavior modification. Prove to yourself that you can't do it on your own, and you need the surgery in order to gain back your life and health. Also, no uncontrolled psychiatric drug or alcohol problems. That should be obvious. Lastly, you need to clearly understand the risks and commit to lifelong follow-up. We do want you to understand what you're getting into and the long-term ramifications of that decision. When we talk about types of procedures that are offered, there's some terminology to understand. The first is malabsorption. We can manipulate the GI tract so that when you eat something, only a portion of what you eat is actually absorbed. The remainder passes through the system. A few decades ago, we did procedures that were purely malabsorptive, but we found that those procedures weren't healthy, so we don't do those anymore. The second term to understand is restriction. We can change the GI tract in such a way that you can't eat as much as you were once able to. We do procedures today that exert most of its effects by pure restriction. The gastric band is an example. But there are also procedures that are a combination of malabsorption and restriction. The GI tract is adjusted so that you can't eat as much, and a portion of the food that is eaten is not absorbed. Those are combination procedures, and the gastric bypass would be an example of that. Now, over the past decade, research has shown that calling a procedure merely restrictive, malabsorptive, or a combination is very simplistic. These procedures exert a powerful effect on the body's hormones. The stomach isn't just a big bag that accepts food and sends it downstream. The stomach is in constant communication with the other portions of the GI tract, with the liver and the pancreas and even the brain. In obesity, this communication system is broken and dysfunctional. After surgery, the normal communication is restored. So these procedures are more than just malabsorptive or restrictive, they are hormonal and metabolic in nature. Historically, there have been dozens of procedures that have been performed for weight loss. Today, most of them are little more than historical interest. Everything has basically gravitated to three main procedures. The first one I want to discuss is the Roux-en-Y gastric bypass. This is the procedure that has been done since the 1960s. This is the procedure that everything else is compared to and is considered the gold standard. It's been around for decades and has the best results. Basically, you take a little piece of stomach and separate it from the main body of the stomach. This creates a pouch that receives the food that you eat. The intestines is then divided and rerouted back to that pouch. So now the food goes into the pouch and into the intestine and bypasses the stomach completely. This results in a restrictive and malabsorptive procedure, but as we discussed, it also exerts a powerful hormonal and metabolic effect on the body. This procedure is the more aggressive of the procedures as it relates to weight loss and resolution of medical problems. Excess weight loss is in the 65 to 80% range on average. Excess weight loss is a term that is important to understand. If you're 100 pounds overweight, that's considered your excess weight. So an 80% excess weight loss for you would be 80 pounds. It's also important to understand that those are averages. So it includes people who are doing all the things that they're supposed to do after surgery, and it also includes people who basically had the surgery and changed nothing as it relates to their lifestyle and eating habits. There's no reason why you can't throw yourself into the post-operative program and increase your odds at being at the high end of this weight loss range, or perhaps even lose down to your ideal body weight. Not only is excess weight loss outstanding with the gastric bypass, but it also has a profound effect on certain medical conditions. The bypass has been shown to resolve diabetes 83% of the time and improve diabetes 93% of the time. High blood pressure can be resolved 67% of the time and improved 87% of the time. And high cholesterol improved over 95% of the time. So you can see the gastric bypass has a powerful effect on common obesity-related medical conditions. The second procedure is the sleeve gastrectomy. Currently, it's the most common procedure performed in the United States. In my own practice, this is about 60 to 70% of the bariatric procedures that I perform. Basically, we turn a sac-like organ into a banana-shaped organ by removing about 80% of the stomach. This results in a restrictive procedure. Removing the top part of the stomach is shown to dramatically reduce and adjust certain circulating hormones in the body. So this also has a powerful metabolic effect on the patient. There are no foreign bodies, and the results are outstanding. Most studies put the weight loss for the sleeve as almost that of the bypass in the 65 to 75% excess weight loss range, although a few studies have shown that the sleeve is slightly superior to the bypass as it relates to weight loss. The sleeve also has great results with diabetes resolving in 60 to 80% of the time and resolving hypertension 60 to 70% of the time. The adjustable gastric band is the last procedure. This used to be very popular. Now I take more out than I put in. It is a good procedure, but not a great procedure. It restricts food intake, but little else. This restriction is produced by placing a band around the top part of the stomach. The band has a balloon on the inside of it. The balloon is connected to a tubing, and the tubing is connected to a port. The port is placed under the skin where it can be accessed in the office. Saline can be injected into the port. The saline then goes into the tubing and into the balloon, where the balloon then tightens down on the stomach, causing restriction. The results are better than diet, exercise, and behavior modification, but are clearly inferior to either the sleeve or the bypass when looking at results. The excess weight loss is around 40 to 50%, diabetes is resolved less than 50% of the time, and high blood pressure is resolved around 40% of the time. So those are the three major procedures. These procedures account for probably 95% of all bariatric procedures being performed today. I've been discussing the resolution of medical problems with each of these procedures, but there is one medical problem that deserves special mention, because bariatric surgery is changing the way that physicians are treating it, and that disease is diabetes. So impactful is bariatric surgery on diabetes that in 2015, when the Cleveland Clinic named the top 10 medical innovations of the past decade, number 3 on that list was bariatric surgery for the control of diabetes. Bariatric surgery really turns the treatment of diabetes on its head. To date, there have been nearly 24 trials that clearly demonstrate the superiority of bariatric surgery over medications and lifestyle changes for the diabetic. So overwhelming is the evidence, a statement was released by international diabetes organizations and was agreed on by nearly 50 medical and surgical societies. This statement detailed their recommendations for bariatric surgery for the type 2 diabetic. You'll notice that the title of this article refers to metabolic surgery. This is the direction that bariatric surgery is taking. It's not just the weight loss effects, it's the metabolic effects. It's diseases that we're curing. And many of these metabolic effects, including the effects on diabetes, are independent of weight loss. You don't have to have weight loss in order to have dramatic effects on diabetes. In fact, many patients come into the hospital for surgery on several diabetic medications, and they leave the hospital on 0 medications, and they never have to take medication again. And remember, they haven't lost a pound yet, but their diabetes is gone. This is their proposed treatment algorithm for diabetics. There's a lot of information on this slide, and I don't want to overwhelm you with information, but I do want to walk you through this. If you are a diabetic and your BMI is over 40, you get expedited for surgical evaluation, meaning there's no trials of medication and lifestyle interventions. If your BMI is 35 to 40 and your blood sugars are not adequately controlled, you also are sent for surgery. But even a well-controlled diabetic with a BMI of 35 to 40 needs to consider surgery. And poorly controlled diabetics with a BMI of 30 to 35 also should consider surgical intervention. This is the first time recommendations have been made that include bariatric surgery in any treatment algorithm for diabetics. And notice that the recommendations start with the diabetes, not the weight. Historically, bariatric surgeons would start with the obesity, and one of the beneficial side effects of the procedure for weight loss was a resolution of the diabetes. Now we're starting with the diabetes, and one of the beneficial side effects of the procedure for the diabetes is the weight loss. This is a very different thought process, but it's necessary because the stakes are too high. Success with bariatric surgery is well documented and is quickly changing how diabetes is managed by your local primary care physicians. We have just gone through a lot of information about the individual procedures and the potential for resolution of medical problems. But I would be remiss if I didn't point out that complications are possible, and they are possible. In fact, as with any surgical procedure, there is a long list of possible complications. This is a partial list of potential complications. Of course, your own risk will be dictated by a variety of things, from medical problems to previous surgeries and even the type of procedure that you choose. Depending on those factors, your risk of having a complication could range from 2 to 3% all the way to 10 to 15%. But when thinking about complications, it's important to remember a few things. First, the vast majority of complications are minor in nature and can be fixed with simple observation or a short course of medications. For instance, one of the potential complications of any surgery is pneumonia. Most of the time, the treatment is you stay in the hospital for an extra day or two and go home on a short course of antibiotics, and you don't have any more issues with this. The second thing to consider is that the procedure has progressed to the point that bariatric surgery is incredibly safe. The mortality rate for bariatric surgery ranges from 0.05 to 0.5%. That makes bariatric surgery as safe as gallbladder surgery. Again, the risk isn't 0, but it is very low. The third thing to consider is that staying where you are is also risky. In fact, for most people, it's far riskier to be morbidly obese with diabetes and high blood pressure than it is to have bariatric surgery. In fact, one study showed an 89% reduction in the relative risk of death over a 5-year period of time if a person had bariatric surgery versus if they did not have bariatric surgery. And that study took into account the risks associated with the procedure itself. So is there a risk of having surgery? Yes, but the risk of having surgery may be less than the risk of doing nothing at all. When you come for an individual consultation, we will look at your overall health, individual medical conditions with medications, and your health history to devise a recommendation that fits your needs and your goals. After viewing all this information, I hope that you're excited about the possibilities that bariatric surgery offers you. But I also want you to know that you will be asked to make lifestyle changes. And these changes aren't for a few weeks or a few months, but for life. Why are these changes necessary? Because bariatric surgery is a tool, not a cure. With bariatric surgery, we will give you the most potent tool in the tool chest when it comes to combating obesity and the associated medical problems. But you have to use that tool effectively. If I give you a shovel and you turn it around and start digging in the dirt with the handle, that's not a bad shovel. You just aren't using the tool properly. We will give you the tool, we will teach you how to use that tool, but you have to wield it effectively and efficiently. But you'll have plenty of motivation to utilize your new tool. I've already discussed the weight loss, and that's motivating. I've already discussed the resolution of medical problems, and that's motivating as well. But one of the most exciting aspects of bariatric surgery for me is the improved quality of life that accompanies the weight loss and the improved health. 95% of patients say that they have experienced a significant improvement in their quality of life after their procedure. This means that you can play with your children and grandchildren. This means that you can have fun on family vacations. This means that you can walk upstairs and tie your shoes without experiencing pain. These are the things that make life exciting. These are the things that make life worth living. You don't have to live your life struggling to do the easiest of tasks. These procedures can make a difference for you, and we want to help you achieve those goals. Speaking of quality of life, you remember my patient Kayla. Her BMI was 57, she struggled with depression, anxiety, reflux, high cholesterol, her diabetes was out of control and she needed an insulin pump. The most frustrating part for her was that she was infertile and was told that she could never have children. Well, in 2013, she had a gastric bypass. In 9 months, she lost over 80 pounds, her cholesterol normalized, and not only is she off her insulin pump, she is off all diabetic medications. And to me, one of the most satisfying things about my job is that this infertile woman who was told that she could never have children now has a baby boy. So if all of this excites you, if you want to change your life, we want to be a part of your story, and we hope that you will give us that opportunity.